let's get to treatment then.
Okay.
What happens first when somebody comes to see a sleep specialist such as yourself?
So generally, of course, we want to take a good history. And that may require the use of something called a sleep diary, where we actually have patients go home, fill in the diary. It gives us a lot of good specific information about when they might be falling asleep, when they're waking up, what they're doing at night.
You want them to track everything that they're doing with their sleep.
To be very specific and track what they're doing. And then we need to make an appropriate diagnosis. Does this patient have insomnia disorder? Are there other comorbid conditions that are playing a role here? Once we've done that, we often will move into behavioral therapy, something called cognitive behavioral therapy, improving sleep hygiene. This generally is something that needs to be done with a sleep therapist, and can be quite effective. In fact, it's probably first-line therapy for most people with insomnia at this point, before even going to a medication. And then, farther down the list, we start thinking about pharmacology. And we really have a lot of medications available in our armamentarium, and each medication is different. It's really patient-specific. You can see the list here. This is sort of an all-inclusive list. It's not just including FDA-approved medications, but of course
which would lead right to the first one, which is not FDA approved.
No,
we're just talking what a lot of people
not.
use just to try and get themselves to sleep. They're trying to self-medicate.
Yes, yes, it's a very, very important concept. There's a lot of self-medication that goes on here, and certainly alcohol is one of those self-medications. Alcohol, by the way, is really not a good sleeping pill. Alcohol tends to put you to sleep very quickly, but after about 3 or 4 hours into sleep, as the alcohol is becoming metabolized, that tends to be very disruptive to sleep.